These past 2 weeks of my palliative care fellowship were not only the 2 hardest weeks of the actual program, but also probably the hardest 2 weeks of my entire medical career. So let's go ahead and talk about it because it was quite the experience. What's going on, you guys? My name is Tochi. For those of you guys that are new, I am a hospice and palliative care fellow, currently in my 11th month mark of my 13-month program. And it's going by really quickly. I haven't dropped a update video for you guys in quite some time. I think the last time we spoke on things, it was about my 3-month mark. And so much has happened since then, which I'll do a little bit later about specifically talk about what's happened in that time. But I wanted to talk about specifically about these last 2 weeks in my fellowship. For those of you guys that are new to the channel, not really sure how a palliative care fellowship is set up for physicians, usually you are doing a lot of inpatient time and outpatient time and hospice time. But 2 of those weeks, you need to do pediatric time. One of the things that I was kind of nervous for going into this rotation is because during my med school years back in 2020, when I was doing my pediatric rotation, it actually got really affected by the pandemic. And because of that time, med students were not allowed to do inpatient time for pediatrics at my school, at least. And I was actually specifically only doing pediatric care on the outpatient setting in the clinic. Now, this was hard for me because I was originally interested in pediatrics for what I wanted to do for residency. It was either internal medicine 1 or pediatric a close number 2. And because I didn't actually have a full experience for pediatric care and what the rotation was like, I was like, okay, I can't go for pediatrics if I haven't rotated through in a full experience. And I was like, I'm not going to jump into something that I don't really have experience with. So although it was my second choice, I was like, I'm going full force for internal medicine. And I was able to go through that and graduate that and get my license in that as well. Because of the time that I missed for pediatrics, I was kind of nervous because 1, I hadn't managed any pediatric patients in the past. 2, now I'm also managing pediatric populations in a palliative care sense, so serious illness or even at end of life. I really like kids, but I knew for myself, I wasn't really sure if I can really see kids in that context really, really sick. In the outpatient setting, seeing them in clinic, I was like, okay, this isn't that bad. Like, we're getting shots, we're doing all of our normal kid care. But for this rotation, I was specifically in the neonatal ICU and the pediatric ICU, the NICU and the PICU for short. Although this was a very emotionally taxing and very sad rotation, it was quite the eye-opening experience. And the reason why I say that is because the amount of resilience that you have to be or have to be able to be in this specific field of pediatric palliative care, it's off the charts. And the 2 attendings that we had, or just specifically to talk about the team makeup, we have 2 attendings that switch on and off every other few weeks or so. We have a nurse practitioner that's there every week, and then we have a chaplain. This is a very small team because compared to my adult inpatient palliative care team, we have 2 attendings on at all times. We have 2 nurse practitioners that can see their own patients as well. We have 2 social workers, and we have a chaplain. And that's a way bigger team. And although the patient lists in terms of how many patients that we were seeing on a week-to-week basis were about similar, maybe 20, 22, 24, 26 patients, because the adult team was so much more well-staffed, had way more people, divide and conquer was so much more easier for that. For the pediatric team, we only had like 3 people at a time. And that's with me being added, that's 4 people. That's really hard because when you have way less people and you have the same amount of people to see as compared to the adult team, it is very, very busy. And one of the things that I actually noted, and one of the things that my fellow told me or co-fellow told me before I got on, because I was the last fellow in my class to rotate through pediatrics, is that you almost never sit down, which is crazy. Like, I came in, I rounded on my patients, we talked about them before, and then as soon as we stepped up and started walking around the hospital seeing all our patients, we did not sit down like that much at all. The reason why is because we have way more patients to see, and I felt that the amount of communications that we had was pretty much off the chart. We were talking to almost every single team. We were having a lot of family meetings. We had a lot more family meetings in the pediatric side of things. And maybe it's because we had to give very specific up-to-date updates as opposed to like in the adult side. I feel like things kind of take some time to change, but for the pediatric side of things, I feel like things were changing almost on a not quite hour to hour basis, but at least shift basis. And so many things were changing and so many updates were coming in on a day-to-day basis. It was quite crucial for us to have these meetings for the families. And I would say that for the past 2 weeks, how many official family meetings we had. I would say we had about 4 to 5 official family meetings, and then maybe a bunch more in terms of like unofficial visits with the families. But that's one of the things that I noted was that the amount of communications we not only had with the primary teams, but also the other subspecialties, and then also trying to coordinate meetings with everybody there to try to get a clear message across, that was happening a lot. That was happening a lot. One of the other things that I noted during this rotation that was quite difficult was also knowing what to say for the parents of the children that you're taking care of. And that's one of the differences that I noted for pediatric palliative care as compared to adult palliative care, is that the surrogates that you're speaking to, or the representative for the patient, is parents. And a lot of times it's very young patients and young parents. So a lot of them were in their maybe early, mid, I've even had some like teenagers, and seeing that this was supposed to be a very, very happy time for them. They just had a baby that was born. They are expecting to have a baby and then go home. Now they're here for months on end. And the amount of grief that they're dealing with after what was supposed to be a really, really happy time for them was really tough to see. It was really tough to see. And I couldn't even imagine losing a child at that young of an age early on in my life. And it was just something that I was like, I don't even really know what to say. So seeing how my attendings were able to maneuver conversations, guide them through this process was quite amazing for me to see. And not only am I going to be taking away a lot of different strategies or, workflows that my attendings use, or even like the nurse practitioners or APPs use, I'm going to be taking a lot of those methods and applying it to the adult world. Because although the conversations are a little bit more nuanced and different for pediatric care, there's still some things and some qualities that I can take away from it to adapt to my own care when I start practicing as attending in a few months. One of the other things that I noted that I wanted to speak to as well is that there was a lot of resources for parents, because of the hospital that I serve in and how big of the county that we cover. A lot of people are coming in for miles away, like 30, 40 miles, just to get care at our hospital, because there's lots less pediatric specialized places out there, or places that can handle pediatric patients. I remember I was talking to this one patient, they're like, yeah, we don't really have like a place that we can just take our baby to that is more specialized in pediatric care. So we're coming from like 30, 40, 50 miles away to make sure that we get the optimum care for our child. And that's scary, because these children are such vulnerable populations, especially the one with the congenital abnormalities and things that you need quite frequent checks. And one of the resources that we noticed is that we had like these kind of like hotel stays, almost pretty much, that are on the campus of the hospital. And what we do is that they get vouchers from our social workers to be able to stay there for long times, because some of these patients, and I noted this was also a big difference as well, is that some of these patients can be in the hospital for months, which was crazy, because I was looking at the actual list for our patients, and one of the actual columns that I have is length of stay. And usually for the adult population, a normal length of stay is maybe like a week or two. But for the pediatric side of things, especially in the neonatal ICU or the pediatric ICU, some of these kids can be there for months on end. I remember what was the longest one I saw? I think one of them was like they're in the hospital for 4 or 5 months, which I was like, whoa. Like, I thought it was a typo almost, but no, that's a reality for a lot of these children. Another difference between pediatric palliative care and adult palliative care is that with the pediatric side of things, there's this auto consult system where essentially if this criteria is met, then our team is automatically involved. And one of the more common situations that was actually occurring is if a baby was born premature. So in that early 20s weeks, that is an automatic consultation. Although we don't have a lot of things to manage specifically, it is expected that if a baby is born premature, they're going to be in the hospital for a very, very long time, almost until the month of when they're supposed to be born. So if they're born in that 21 or 22 or 23 week month, then they're often in the hospital getting that support throughout the entire time, and they don't leave the hospital once, which is very difficult, because especially if they're very sick, specifically if they're intubated, needed a trach, they cannot get that skin-to-skin contact with their mother. The breastfeeding, getting a lot of nutrition in them was very difficult, because a lot of times babies that are born premature have GI issues. They're not able to just eat things by mouth or drink things by mouth to get that nutrition. They need to have TPN, PPN, artificial hydration and nutrition to get all that in. Some of them are getting central lines. Some of them are getting, the fact that some of these kids are getting tracheostomies was, it just blew my mind. And another thing that I noted too was that because I didn't have a lot of inpatient time during my med school experience, I I've been around children before, mostly after they've been born full term, but I haven't ever seen like a premature baby before. So seeing the size of them, I wish I had it on me now, but they gave me one of the diapers for for the premature babies, and the diaper is like this small. Like I could fit the entire diaper in like the palm of my hand. And some of the children are just so small and fragile. And like I'm just looking at them, I'm like, wow, like you're gonna turn into a full grown adult one day, but you're so small right now. It was just so mind blowing to me that it was just like a huge appreciation for life, and also a very big downer for myself because I was like, I really hope you make it through because you are born premature. And a lot of times, babies that are born premature do not make it, even though we've had very big advances in medical care. Yeah, that was just something that was just quite somber for me. I think the reason why these last 2 weeks for me were very difficult, not only because I don't manage pediatric patients, but was some of these patients are very sick, and the things that they're getting that are like out this world for the adult population, seeing a baby intubated, seeing a baby with a trach, seeing a baby on pressors or with a central line or on ECMO, that's on ECMO. Shh. And for those of you guys that are not aware, ECMO is pretty much a device outside the body that your blood gets filtered through it, oxygenated, and brought back to you. And the reason why people get on ECMO is if they're having a heart issue or a lung issue that's pretty severe and refractory to any other mechanism that we try to do. And usually ECMO is the very last resort of things that we do. So if you're not able to make it on ECMO, then you're not going to make it at all. And seeing a baby on ECMO when I was just getting familiar, because the hospital residency program that I was at, they didn't do ECMO, but I've heard a lot about it. But seeing the machine that was running the blood back into them and just seeing them on the bed and just, man, they're just going through so much at such a young age. And it was just quite astounding to me. And it was just really hard for me to see that, and also really humbling for me because it wasn't my child, and having to be the one to lead a lot of these goals of care conversations and meetings with these parents with what was supposed to be a happiest time for them, having a baby, having them born, taking them home. Those first moments, all of those things are just filled with them being in the hospital and having to make hard decisions on a day-to-day basis, wondering if that call they're going to get is going to be bad news. It was just so stressful. So a lot of these parents, it was interesting to see their responses to things. Some of them were numb, some of them were emotional, some of them were crying, some of them were upset, bargaining, all the 5 stages of grief. I saw it in the actual ICU. And I thought I saw it all when I was dealing with ICU care or palliative care in an adult sense, but I was only really scratching the surface of what palliative care can really see. Yeah, it was a really hard rotation. It was a really hard rotation. Today was the last day. And although it was a very hard rotation, I wouldn't take it back for the world, because the things that I saw from there and some of the techniques and some of the strategies that I'm going to use for even in my adult world as I start as an adult palliative care physician in the attending sense, there is so much that I learned that I can apply, and then so many resources that I learned about for parents that have very sick children and how to kind of maneuver their care. That way I can kind of best serve their needs to be able to be the best doctor that I can. But it was quite the experience. And I hope to give you guys more updates in the future in terms of what the fellowship is like. And I'm going to talk a lot more about later and give you guys updates for the following rotations. But now that I finished this last 2 weeks of this rotation, we are in the 11th month mark, and we have 13 months, and we have hit halfway through the 11th month mark. So we have about 4, 8, 10 weeks of the fellowship left. And then after that, I'm going to be starting my attending job on September 1st. So I'm looking really forward to that. I'm going to drop a video later on about that job and what the job process was like, getting my first attending job and going from there. Let me know, have you guys had anybody that had a baby that's born premature? What was that experience like? Let me know in the comment section down below. We should start a dialogue because I want to see how things were for you guys on the patient side of things. So I'll see you guys later. Peace. Have a nice day.